Afternoon, everyone, and welcome to today's Viz AI webinar, Redefining ICH Systems of Care with Advanced AI Solutions. I'm Chelsea Summerhour, a clinical manager here at Viz AI and a proud neuronurse by training, and I'll be your moderator for today's session. I'm joined by two truly outstanding clinicians from Mount Sinai Health System, who will walk us through how artificial intelligence is advancing intracranial hemorrhage care, helping their teams make faster, smarter decisions in some of the most time-sensitive scenarios in medicine. First, we'll hear from Dr. Christopher Kellner, neurosurgeon and director of the Intracerebral Hemorrhage Program at Mount Sinai. He'll walk us through the validation of Viz ICH and ICH Plus, including how these tools compare to traditional approaches. Then we'll hear from Dr. Neha Dengayak, associate professor of neurosurgery, neurology, rehabilitation, and human performance. She'll be sharing some real-world experience, including a powerful case study that highlights the impact Viz can have on workflow, transfer times, and outcomes. Together, they bring really deep expertise in both the science and the systems of care. Now, before we dive into the main agenda, I'm so excited to share some important news with all of you. Viz SDH Plus has just received FDA clearance. It's the first AI solution that automatically measures all subdural collections, including subdural hematomas of any chronicity. It will quickly and automatically deliver precise measurements of volume, max thickness, and midline shift directly from the scan. We built this solution to ensure that care teams have the information that they need to decide upon the appropriate treatment pathway, especially as this patient population grows and the clinical management strategies continue to evolve. This new clearance builds on the existing Viz hemorrhage portfolio. We started with detection. Viz ICH identifies suspected acute bleeds within the skull, and Viz SDH flags suspected subdurals regardless of their chronicity. But we heard clearly from the field that detection alone wasn't enough. Often providers need more clinical context to help guide treatment and transfer decisions. So we built two more algorithms. Viz ICH Plus quantifies hyperdense volume, lateral ventricles, and midline shift, automating what was before a burdensome and often inconsistent manual process. And as we've just seen, Viz SDH Plus will provide volume, max thickness, and midline shift for subdural collections, bringing the same level of precision and consistency to SDH workflows. All of these solutions are fully integrated into the Viz platform. They deliver real-time notifications, and with our measurement algorithms, you can even threshold those notifications so that each user receives alerts that are most relevant to their role in workflow. And because these tools are part of the broader Viz platform, they come with the full suite of communication and care coordination features, enabling fast collaborative decisions across teams and sites. Together, this portfolio supports faster identification, smarter triage, and better care across the entire hemorrhage continuum. Now, before I hand things over, I want to pause on a concept we all know well: time is brain. While we often associate this with ischemic stroke, it can be just as critical when it comes to hemorrhage. And this urgency is backed by evidence. The 2024 AHA-ASA scientific statement recommends a door to CT time of 25 minutes or less to improve ICH care. And that really emphasizes how important early recognition is. In the ENRICH trial, patients who were treated within 24 hours of symptom onset spent fewer days both in the ICU and in the hospital overall compared to those who received medical management. And these are really meaningful differences, both clinically and operationally for patients and for healthcare systems. And with that, I'm going to turn it over to Dr. Kellner, who will walk us through the clinical validation of Viz ICH and ICH Plus. Chris, the floor is yours.
Hey everybody, Chris Kellner here from Mount Sinai. Thanks a lot for inviting me to speak and share our work evaluating the Viz ICH algorithms. We did two studies over the last few years. The first one was evaluating the accuracy of Viz ICH, identifying ICH on CT scans performed for stroke codes. And the second one was validating the ICH volume and intracranial hemorrhage volumes that were calculated by Viz ICH Plus. So I'll bring you through both studies and start with the detection study. Looking at intracerebral hemorrhage, a passion of mine, 10 to 15% of strokes are ICH, and it's associated with high morbidity and mortality. 40% 40% of ICHs are fatal within 1 month, and only 12 to 39% of people regain long-term functional independence. So one of the most morbid forms of stroke. Viz-ICH became available for research a few years ago and then more recently for clinical use. And this detects the presence of ICH or intraparenchymal hemorrhage on a CT scan. You can see here, it is presented in the app the same way that we've become familiar with large vessel occlusion being presented. And you're able to scroll through the image and identify on your own where the ICH is and see an image of that in multiple different planes. This study, called Pilot Deployment of Viz Intracranial Hemorrhage for Intracranial Hemorrhage Detection, a real-world performance in a stroke code cohort, was published by one of our research fellows, Stavros Matsoukas, and you can see the rest of our team there a few years ago here, 2022, in stroke. And we looked at stroke codes over a period of time, and we looked at 5,000 stroke codes. And we used the Viz algorithm, and here is a sequence of how the algorithm is working. And initially, you've got metadata filtering, where the CT is looked at in the Viz algorithm app. There's some pre-processing that occurs. So there's resizing, there's clipping of the image, and there's normalization to a certain number of voxels. Then there's segmentation, and you can see it's fed through a deep convolutional network trained to identify hyperattenuated regions consistent with ICH. There's thresholding applied, and then finally the algorithm outputs whether or not an ICH is present. If so, then the team is notified, and we've become familiar with this over time and quite dependent on it, where you can set alerts for the team to be notified for a specific disease process or on call or off call through the app. The way we designed this study is we retrospectively looked at our radiology database at Mount Sinai throughout the entire health system, and we looked at stroke code non-contrast CTs. We were able to then exclude CTs that had contrast in them, contrast contamination, and metal artifact. From that, we were able then to identify 5,000 CTs from May of 2019 to September of 2020. And of those, the Viz-ICH algorithm automatically assessed 3,389 scans. So we looked at the accuracy metrics within those 3,389 scans. The diagnostic values we calculated were 84.7% sensitivity, 99.3% specificity, 90.5% positive predictive value, 98.9% negative predictive value, and 98.3% accuracy. And you can see this is a pretty standard stroke population with a mean age of 67, approximately half female, half male, and then a prevalence of ICH of 6.9% throughout the entire population. We also looked at the accuracy of the algorithm for different subtypes. There were only small numbers in each of these, but these are the sensitivity values for intraparenchymal hemorrhage, intraventricular hemorrhage, subarachnoid hemorrhage, and subdural hematoma. And you can see for subdural hematoma, a different algorithm was later developed that's specific for subdural hematoma and is its own Viz algorithm that you just heard announced just became FDA approved and available clinically. So in conclusion, that first study, we saw high performance of the Viz-ICH algorithm and high accuracy in a real world setting. Of course, we recommend clinical interpretation by an experienced radiologist in addition to the Viz-ICH app to identify ICH and interpret the scans. Within our practice, Viz-ICH provides our multidisciplinary neuroendovascular team with early notifications, just like we got used to with large vessel occlusion, so that we can focus our attention on the scans that show ICH and we can mobilize our clinical team. We also, at Mount Sinai, use this to mobilize our research team. So that was our Viz-ICH algorithm accuracy evaluation. And now let me get to the more recent study we did evaluating the volume calculation feature of Viz-ICH Plus. The background here is that over time, the management of ICH and IVH has required volume calculation. You heard earlier the Enrich study within 24 hours. That study had a certain volume range, approximately 30 to 80 cc's. Other minimally invasive ICH and surgical trials have had volume ranges, and other medical trials have had certain volume ranges. And so the treatment of ICH increasingly has become a volume-dependent algorithm, and the research studies also depend on patients within certain volume ranges. So rapidly identifying the volume in a way that is adjudicated and agreeable among all parties in the multidisciplinary team is extremely valuable for rapidly activating the team. Viz ICH Plus, you can see the app here, works similarly to the other algorithms that we've gotten used to. And you can see what's interesting here is you get the identification of multiple different intracranial hemorrhage compartments. Here's ICH, here's intraventricular hemorrhage, and you can see midline shift calculated there. And then you can see the left ventricle hemorrhage. So you're getting these segmented volumes separately segmented. And I found that very helpful over time. Obviously, if you're calculating the volume of the ICH, you don't want the ICH and the IVH volume added to that. So fortunately, the algorithm is able to detect where the hemorrhage is and to segment those separately. So in this particular study, what we did was we retrospectively looked at 139 patients who presented with ICH, and we performed ABC over 2 calculations, and we also performed semi-automated segmentation, which is threshold guided. We used a very commonly used free application called Slicer for that. And you can see here's an example of ABC over 2. This is the calculation we're all very used to doing, quick and easy on PACS or through Centricity. And then you can see here's Viz AI identifying and showing you automatically the volume of the hemorrhage and exactly where the hemorrhage is. What we saw here was that the Viz ICH volumes were closer to the segmented volumes than ABC over 2 was. So it seemed like using the segmented volumes as the ground truth in 77% of cases, the Viz ICH volume was more accurate than ABC over 2. And that makes sense that that would be the case. And it's about how much faster can you get that number. It was faster than semi-automated threshold guided segmentation in all cases. The average time to calculate the volume, and we had people measuring how long it was taking them to do these segmented volumes. It was 424 seconds. So quite a few minutes to calculate the segmented volume. So you can see time to process imaging and output to the clinician-facing mobile application was much faster with the algorithm, obviously, than doing the segmented calculation and even ABC over 2. So in conclusion, Viz AI ICH Plus is able to more accurately estimate ICH volume than ABC over 2, which we've been commonly using clinically, and it's also faster. So 2 advantages that make it extremely useful when we're triaging these patients in real time. And I'll hand off to Neha for the second half.
Thank you, Dr. Kellner. I just really wanted to ask you, I can understand how important the speed and accuracy are within your workflow, but what does that feel like to you in the care of a patient? How is it different from before you had access to this technology?
I think another point that I didn't make just a minute ago is that ABC over 2, which is what we're able to use in real time, has a lot of inter-observer variability. So you'll have one person measure it or estimate it and say, this is a 22 cc hemorrhage. And then you might have another person say, this is a 35 cc hemorrhage. Obviously, one of those patients is going to get enrolled in Enrich or going to get treated with minimally invasive evacuation if you're already going by the Enrich criteria, and the 22 cc hemorrhage would not. And so it really matters what the exact value is, and having the accurate and kind of universally adjudicated. Everyone sees that number and they know, okay, that's the number we're going to go with. That's what the algorithm said. We know that it's accurate, and it can be obtained quickly. That really does sort of limit the debate around what is the real hemorrhage size, and it really does matter. It determines what procedures or medications the patient's eligible for, and also what studies they're eligible for. So it really has made a big difference in how quickly and how confidently we can triage these patients.
Thank you so much for that insight. Now, let's hear how this plays out in clinical practice. Neha's going to walk us through a real-world impact study on how VIS has impacted ICH workflows. I'm going to hand it over to you now.
Thank you so much. Thanks for having me. And, as a systems of care scientist, what I'm really looking to do is translate evidence-based medicine to the bedside as fast as possible. What are those barriers to implementation? And how do we overcome those barriers to improve adoption of whether it's innovations, whether it's randomized controlled clinical trials? So how do we do that? So we published this case study looking at our how we leveraged the Viz ICH Plus algorithm, and I'll talk to you about our systems of care for ICH. So this is a patient who was 47 years old, had a history of hypertension, and suddenly developed severe headache, nausea, vomiting, and then presented to one of our EDs. So went to Mount Sinai, Brooklyn, where a head CT was performed, and you can see on his CT head, there's a right parieto-occipital ICH. The CT was performed at 16:47 p.m. And then within 2 minutes, our neurosurgery team, the frontline clinical team, research teams were all notified on their phones using the Viz AI app. At 16:50, neurosurgery reached out to the resident as well as the neurocritical care attending at Mount Sinai West. That's our center of excellence for all the ICHs. So we try to triage all our patients to Mount Sinai West. So after checking with the Mount Sinai West team that, hey, we have a potential patient, neurosurgery reached out to our boots on the ground, Mount Sinai Brooklyn stroke team, and it was determined fairly quickly that the patient would be a good SCUBA candidate. And you can see with the ICH Plus algorithm, we're seeing the ICH volume here. So the patient met criteria for our minimally invasive clot evacuation technique, and 100% of that ICH was effectively evacuated through this minimally invasive technique. Just some representative scans here. So the patient made a nearly full recovery, lives at home with his wife. He does have a mild visual field deficit for which he wears prism lenses. So how do we reduce the times to transfer? Inter-hospital transfer can have, and we look at literature, we know that some patients who undergo inter-hospital transfers can have worsened outcomes. There could be delays in transfers. Patients can deteriorate during transfers. How do we uphold time as brain when we're moving one patient from their presenting location to a location where they can get potentially definitive treatment? So in this particular case, we were able to reduce transfer times from our average, and we previously published our transfer times for ICH patients who are being evaluated for this minimally invasive surgical ICH technique called SCUBA. In our previous experience, we've shown that it takes about 200 minutes median to do this for our patients, to move them from the presenting hospital to the receiving hospital. In this particular case, we were able to reduce that time because we leveraged this pull model rather than a push model, where an expert saw the imaging and very quickly determined that the patient would be a candidate for MIS. So faster care, we think, was enabled by this more rapid detection of ICH, and rather than waiting for the radiology team to then notify the ED provider, then notify the command center, then loop in all the expert teams, we were able to do this potentially faster because of faster detection and notification of expert teams. So just on the right-hand side, you can see this flow diagram of how we facilitated this patient's care. And essentially, patient presented to this hospital, to Mount Sinai Brooklyn with symptoms. CT scan was performed, analyzed by Viz ICH. We got the detection. We also got the volume with ICH Plus, the stroke team, the neurosurgical team, neurocritical care, our command center. So we already have this kind of system in place in order to facilitate rapid treatment. And the patient was eventually transferred over to our ICH Center of Excellence. So just a process level map for what happened where for our patient. So patient presented with symptoms at the transferring hospital, non-contrast CT head was done, Viz ICH Plus, both for detection and then volume calculation, and generated this alert that came to our phones as the potential receiving teams and expert teams. And as soon as we received that, we had this conversation. We determined the patient would be a candidate for MIS, got in touch with the boots on the ground stroke team and ED teams at the transferring hospital via our command center. The command center coordinated sending out the ambulance and all the logistical arrangements. And the receiving hospital, which in this case was Mount Sinai West, prepared for patient arrival. Patient underwent their scuba and showed improvement over time. So with this case, we highlight how integrating technological advancement in the detection and calculation of the volume of ICH by using ICH Plus can be seamlessly integrated into a systems of care approach to ICH. We've had our Neuro Emergency Management and Transfers, or NEMAT program, in place now since the latter half of 2017. We do about 1,000 neuro emergency triages every year. So I'll stop there, Chelsea, and hand it back to you.
Awesome. Thank you so much. And I know that a lot of people are probably interested in how you and Dr. Kellner and the rest of your team have built out this Center of Excellence. Is there any advice you can give to other programs who are interested in doing the same?
Absolutely. It's very important, one, to have this commitment to getting the right patient to the right place at the right time every single time. And we need to be able to parallel process and leveraging this multidisciplinary care, both on the clinical side as well as the process level side. What I mean by clinical decision making is determining whether a patient is going to be a candidate for specific types of therapies or not. When we came up with the idea for the NEMAT program and coordinating care in a complex urban health system, we wanted to make sure that we didn't miss a beat and patients did not deteriorate as they were waiting to be transferred, and care could be delivered seamlessly from the hospital that they're presenting at and in the back of the ambulance. And then by the time we receive them, and as we're moving them either to the endovascular suite for their scuba procedure, or we're moving them up to the ICU for further monitoring. And then what preliminary recommendations do we need to provide to the boots on the ground ED physician or the stroke team that is going to co-manage those patients with the ED physician? And not every patient needs to get transferred. Then how do you make sure that you're able to decide appropriately and build some capacity at the different sites that your health system may have within or be affiliated with? So it took a lot of buy-in from our frontline teams, as much as it was easy to convince a lot of people, because our leadership believed in this vision of leveraging our systemness and seamlessly integrating evidence-based medicine and revising our protocols and making sure that we overcome those barriers and we amplify the facilitators for whether it's the adoption of new technology or the results of a randomized controlled clinical trial.
Thank you.
I don't have much to add to that. Neha really covered it. Great answer, Neha. I think it's really about focusing on ICH and developing multidisciplinary protocols, like you said, and measuring how you're doing in the same way that we measure so many different features of our ischemic stroke care, measuring similar features in our ICH care, and continually reviewing those and trying to improve your systems of care around it.
Great. There's a question in the chat. Are you using this for transfers outside of your healthcare system or just within your healthcare system?
Great question. Yes, we are using it also for transfers outside, and that does require a little bit of upfront work, obviously, to make sure that the other hospitals are also on the same network of Viz that you've got set up on your systems network. And we have been able to arrange that with numerous different hospitals that are not affiliated with Mount Sinai, but do often transfer patients to us with LVOs and with ICHs. So yes, we are using it outside the system, outside the health system, very smoothly.
Mm-hmm. And when you're building out programs like this, how important is it to have a tool like a Viz AI or another way to coordinate care across the system that you're building?
That's a great question, And when we think about moving patients from one hospital to another, we're all very aware of the threat of fragmentation of care. Information gets lost. There are delays. The preliminary recommendations that you might want the frontline team to implement may not get implemented, or a patient's clinical condition may change. There are so many different variables. So it's not a decision without calculated risk when we're moving a critically ill patient with an ICH from one hospital to another. So how do you ensure that the delivery of care and access to data throughout this process, even if patients are moving from one location to another in the back of an ambulance, that you're not losing any data? So with that in mind, leveraging integrated technological platforms where you have imaging review and you're also able to communicate with clinical teams. How do you integrate that eventually into process level communication into your EHRs? And that's been a concerted effort for us. And we've been very intentional about moving this up notch by notch into creating as seamless of a process as possible, so there are no delays and there is no loss of information and we don't miss a beat. So essentially there is this continuum of care rather than, you're playing catch up by the time the patient gets to you.
That's great. Anything to add, Dr. Kellner?
Once again, Neha really covered it. So out with this one.
No, because we work really well together, right? As multidisciplinary teams. Like, it's so wonderful. As a neurointensivist, I could not have asked for better surgical partners, and I could not have asked for better leadership's vision in investing time, energy in leveraging different kinds of technologies and making sure that we're not just thinking of technologies as an afterthought, but technology innovation is part of our movement to change how we deliver care and how we improve our systems of care. And particularly for a disease process like ICH, I think it's imperative because it used to be riddled with this, nihilistic attitude that ICH patients would not do well, and then we would not offer aggressive therapies to them. And that has totally changed. We've got to leverage time as brain for ICH as much as for any other stroke type.
Yeah, I think also the collaborative feature of the app I really like, because it sort of socializes the management of each patient a little bit, where there's not a phone call to one person who's making the decision. There's a multidisciplinary agreement in a text chain, that's HIPAA safe in the app under that patient's profile, that makes it by default a multidisciplinary decision each time. And I find that to be really helpful in having coordinated management. And so that's also a great feature.
I want to ask one more question before we close, because I think it's very interesting to many of our attendees. This person asked, how do they communicate the value of a solution like this to the people who are actually paying for it? They're staunch supporters of advanced AI measurement, but they need to make the sale to their leadership team that this is something that should be purchased by their system. Can you provide any insight into how to communicate the value of a solution like this?
Of course, they should listen to this webinar. No, besides that, no. But in all fairness, right? I think we're living in a world where we have the ability to leverage various technological advancements, particularly AI-driven tools, for improving patient outcomes, for improving the delivery of care. And how do we communicate the value in order for us to understand both moving the science as well as ensuring that I said this previously too, we're lucky to work in an organization which is very technology forward. However, if you happen to work at an institution which is not as supportive of newer technologies, then how do you communicate the value? So one, we've got to be very intentional in communicating the value and ensuring that leadership recognizes that it's not just a matter of choice, whether you're going to leverage AI, machine learning in patient care delivery, but essentially what tools and how are you going to implement and how are you going to ensure that some of these technologies, so the focus should be not on whether we should or should not. I think it's more about choosing some of these tools really thoughtfully for improving the outcomes for specific patient populations. And when you have an early success, I think that success begets more success. So you got to start somewhere, but at the same time, choose from the menu of all the different tools that are available and ensure that you can integrate them into your existing workflows rather than trying to reinvent a whole new workflow. So I think that might be helpful. Chris, what do you think?
I would love to link the use of the app to improved outcomes. I think that we're not going to see a randomized clinical trial of, Viz versus no Viz, because, it's one of those things that's like, it's a natural, you naturally know that it's improving your ability to deliver care. And when you think about how it used to be, it's just really facilitates things to be done more quickly and more seamlessly. So it is hard to quantify, and we're not going to get a randomized clinical trial, but I think we will probably get some historical studies that are looking at outcomes before and after. Those will have some other biases, but I think we'll probably see some outcome studies in the future looking at historical analysis.
Wonderful. Well, thank you both so much for your time. I think we're a minute over at this point. And thank you to everyone who attended today. This is such an important conversation, and we're very lucky to have you both contributing to it.
Thank you
so much.